Hello and welcome to my presentation on Pulse Ox Pleth by Jonathan Grimes. I am the Battalion 1 EMS Supervisor on B Shift. I'm sure most people's first question is, what is Pleth? It is short for plethysmography or a photoplethmogram, and it is the measurement of volume changes within an organ or extremity from wherever the sensor is located. So this can be typically on the finger for our uses, but it is also used post-surgically in organ transplant patients to verify good circulation. In short, it is a visual representation of the pulse. A couple of things that the Pleth is not. It is not similar to capnography. One of the hardest myths to dispel is that it is related to respiratory function. Unlike the pulse ox numeric value, it is not a measure of respiratory function, but actually cardiac function. And the second most important thing is that it is not an excuse to diverge from normal protocols. Additionally, as you can tell here, the capno waveform looks very different from the Pleth waveform, and they both measure two very different things. The simplest way to put it is that the Pleth is the visualization of the patient's pulse. The best way to read it is by placing the probe on the middle fingers of either hand where the vasculature is best. However, as we all know through years of use of pulse oxes, that this may not always be the best or most accurate option. So why do we care about the Pleth? The Pleth can be a valuable additional tool to help assess the cardiovascular status of your patient. It's fast to set up and assess, and it's already incorporated in our LifePak 15s, so there's no additional cost to the department. It's non-invasive, and it's a tool that the EDs and hospitals use all the time. If you're able to explain a Pleth to the doc in the ER, you'll look like a rock star. So, what are our potential uses for Pleth? First and foremost, we use it to verify the quality of the numeric value of the pulse ox readings. Beyond that, we can also use it to verify EKGs, verify pacing capture, distinguishing between PEA and ROSC, and probably most importantly is real-time CPR quality assessment. Additionally, we can use it to confirm hypovolemia in patients. Some of the interesting but not applicable to EMS applications are post-surgical peripheral perfusion, levels of anesthesia, and peripheral artery disease. As science continues to explore the use of this technology, more and more uses are being found for it as well. The way to do this is to use the speed dial, choose which lead you would want it in, press that open, choose your waveform, change to SpO2, hit that, hit our home button, and there we see the Pleth. We can do that in leads 2 and 3, but we cannot do that in lead 1. As you will see here, some of the smaller standalone pulse oximeters that we have started carrying will also show a Pleth waveform. However, these are not nearly as accurate or detailed as the Pleth that is presented on the monitors. A normal Pleth waveform presents as evenly spaced, equally wide waves of equal amplitude. As you'll see in further slides, if the patient's pulse is irregular, the Pleth will be irregular too. One thing to note is that the Pleth waveform has a diacritic arch, which is a secondary upstroke in the descending part of a pulse, corresponding to the increase in aortic pressure upon closure of the aortic valve. Note that not all patients will have this depending on their cardiac function. Here you will see some rudimentary examples of Pleth waveforms. As you can see in normal heart function, the amplitude, width, and spacing of each waveform is uniform, indicating normal heart function. In irregular heartbeats, you'll notice pauses corresponding to the QRS complex on the EKG. Additionally, you can see patients with poor cardiac function will have lower amplitude waveforms. In this example, we see a patient in atrial fibrillation with a corresponding Pleth wave. As you can see, every QRS complex with a perfusing beat will have a Pleth associated. Typically on this monitor, this will show up with a half second to a second lag behind the QRS complex. This is useful to us because it can help us differentiate between PEA, artifact, perfusing, and non-perfusing PVCs. It's also very useful in pacing and ROSC. While pacing, if we have a correlating Pleth associated with the QRS complex, we know that we have mechanical capture. As well, even if we have a patient with very low blood pressure, if we have a corresponding Pleth with return of spontaneous circulation, we know that we have mechanical movement of the heart. One thing to note with this is that they are not mutually exclusive. You may have situations where you do have a perfusing rhythm but do not have a Pleth wave due to the limitations of the monitoring equipment. Here we have an example of a patient in cardiac arrest where CPR is being administered. We notice by the low amplitude of the Pleth that the CPR quality is poor. We are able to see this on the monitor in real time and provide coaching and instruction to the CPR provider. For contrast, in the same patient, when good CPR is being provided, you'll notice that the amplitude, spacing, and size of the Pleth wave is much higher and more consistent, indicating good circulation via CPR. How do we know this to be true? As you'll see in this example, the green line up top is the impedance as measured by the LifePak monitor. This is what's used as the current gold standard to assess CPR quality. Through several research studies and South Metro specific case studies, we have found that impedance and Pleth coincide almost exactly, therefore making it a reliable indicator of CPR quality that is available real time during the arrest. Utilizing the Pleth waveform to verify the numeric value of the pulse ox is where we have a little bit of bleed over into respiratory function. As you can see in the example given, if you have good Pleth waveform, you can surmise that your numeric value of your pulse ox is fairly accurate. However, if you have bad Pleth waveform, your numeric value of your pulse ox is probably questionable. When presented with a bad waveform, try different locations for the sensor until you get a good waveform. That will give you your most accurate pulse ox reading. We can also utilize the Pleth waveform to verify circulation in injured extremities. Situations where you would use this would be compound fractures and highly angulated dislocations. If you place the sensor distally to the injury and find it with a good Pleth waveform, you have verification that there is good circulation to that limb. However, if you do not have a good waveform, this does not necessarily mean you do not have circulation, but should raise your index of suspicion. As you can see in this example, due to the Frank-Starling mechanism, as the interthoracic pressure increases with inspiration, the cardiac output of the patient decreases as seen in the Pleth wave. It presents with an oscillating pattern like the one seen below, indicating that the patient may be hypovolemic. As we all know, sometimes getting an accurate pulse ox reading can be notoriously difficult. Inaccurate readings come from many different conditions such as cold hands, poor circulation, excessive movement, and uncooperative patients. Our suggestion is to try multiple different locations until you get an accurate reading and good waveform. The best practices are to have tissue pass through the sensors versus reflected off of bone, such as placing it on the patient's forehead. Keep in mind that if the finger probe is not working, we have alternate pulse ox sensors, such as the pediatric sensors and the rainbow sticky sensors, that will help you get a better reading. There are several physiologic factors that will affect the reading of the Pleth waveform as well. Things that cause low systolic peak amplitude due to decreased blood volume are elevation of the measurement site above the patient's heart, peripheral arteries disease, and severe hypovolemia. Factors that would create low amplitude due to peripheral vasoconstriction are hypothermia, sympathetic activation, i.e. stress and cold, and vasoconstrictors. Alternatively, factors that create high systolic peak amplitude due to increased blood volume or peripheral vasodilation include arterial blood pressure increase due to increased cardiac output, i.e. an amped up patient, most anesthetics, and epidurals. Demonstrate that the Pleth is independent of respirations. I'm going to hold my breath and I want you to see that the Pleth is unaffected. My final demonstration, I'd like to show that if I cut off the circulation to my finger, that it'll disrupt the Pleth.
It won't be too long later.
Yeah.
It takes about 5 minutes
the
to get...
time difference isn't going to make too big.
Yeah. It only takes about 5 minutes to get to UC from here.
Yeah.
How is that hospital? Is it good?
It's fantastic.
Yeah. We got some awesome staff and doctors there.
I'd take my family there.
Oh, yeah, you're good to flow. I just need a second here. All right.
Trying to figure out where you got cut.
No, it's kind of going in and out.
That's fast.
Any questions, comments, concerns, or errors that you may have found during this presentation can be directed to EMS training or myself. Otherwise, I would like to thank you for your time and attention in learning about Pulse Ox Pleth today. Hope you have a wonderful rest of your day.